Hi guys, good afternoon and good evening. Good to see you all and all waiting for the answers to be discussed. And I felt that this exam was actually just like, I mean, at least the gynae questions which I saw, it was looking as if just what you read and you got the questions according to your preparation. And, not many clinical questions. That's what some students have told me. And the questions which have come to me, I feel that anyone who's read for the last 6 months and has been preparing for the exam would have done gynae excellent. Not good, I'm sure you would have done excellent. So that's the least I expect in a paper like this. So, I've got something like 15 to 18 questions. Some of them didn't look like as if they're from my specialty. We'll discuss the choices as we go, and please send back your feedback. Send back your suggestions rather, because your suggestions will help us format the final set of MCQs, which are used for many teaching purposes later on the app and also in the live sessions wherever we see you with PrepLadder. So, yes, the questions are based on the recalls, and I hope that we have some, constant similarity in the recall in all of you, so that we waste less time and can discuss positively the answers and move on to the next question fast. So let's start with the first question. Are any people here? Yes, guys, they're all here. Chalo, let's start going, and we'll start with the first question which came in Obs and Gynae. A married lady with failed contraception. Don't go with the numbering. The numbering has gone a little wonky because some questions were not from my specialty, some were not included. I included them later. So don't feel if the numbering is not in the correct manner. So married lady with failed contraception with 26 weeks of gestation, what will you do based on MTP Act? Obviously, this language is very incomplete, and the MTP Act, the latest amendment was 2021, March was the latest amendment, and that's why this topic is coming in almost all exams, and that is suggesting that we can do MTP now after till 24 completed weeks. So that act has been discussed in many forums, and I'm sure that you are well aware of that. So what will you do based on the act? Married lady with failed contraception at 26 weeks. Come, tell me. Question was 22 weeks. Okay. See, with 26 weeks, you cannot do 26 weeks. You will no abortion. The question which I am showing you. Now you are saying with 22 weeks. With 22 weeks, obviously, if it is 22 weeks, we can do the abortion because the legal permitted limit is 24 weeks. With 22 weeks, we can do the abortion, and that is done with the the presence of 2 doctors. So 22 weeks, 2 doctors. So if the question was 26 weeks, you cannot offer an abortion. Only till 24 weeks you can offer. After 24 weeks, only in special situations where the baby is anomalous. So after 24 weeks, all of you know, it is only after approval of a board. Otherwise, you cannot do this abortion, right? So yes, I'm sure all of you got that correct. That was a fairly simple one because you've been reading this. Can do with 2 doctors, can only do in fetal anomaly, but for contraception failure, MTP is allowed for 20. I know this Sugandha Pandey. Contraception failure is only allowed till 20 weeks. I don't know where it is written in the act because I have gone through the act. There's no such mention. And there was this mistake done in the, there was a clerical mistake. There was a typographical error that A was marked instead of B when the question was discussed in the champions the exam which was done by PrepLadder. So that I've corrected in many forums, live forums also, and also in forums which are online. So please, all abortions, this act is for all the indications of abortions, whether it is for a person who's got an anomalous baby or a baby mother who is under some serious illness, or there's a rape patient or a patient who is conceived with contraception failure. The criteria is all the same. If there is a abortion required, all these 4 can have an abortion till 24 weeks. Okay, there is no sub clause that nahi contraception failure hai to nahi only till 20 weeks. There is no such sub clause. I have not read it, and if it is there, then I must have a look because this has come to me many times, and where it is coming from, I have no idea. Okay, so please go ahead and say it is for all the 4 indications of MTP that we can do till 24 weeks. I hope that is very clear now. All right, more people will be seeing the answers than the people who attended the LRRs and all the last minute revision programs, I'm sure. So please, okay, it's for all indications that we do abortion till 24 weeks. Please don't get confused about that. Right. Right. So all of you got that correct. It's a fairly simple question. Okay. Chaliye, let's see another question. Now, this one I was not very sure of the choices which came. A mentally challenging girl, challenging hata dijiye. There is a mistake in this. I hope all of you will understand. A mentally challenged girl got pregnant. Next step according to the MTP Act is, yes, guys, come tell me, was this the question or was something else asked in the exam? Partner, self, parents were an option. Okay. I don't know if husband was there because anyway, it's a mentally challenged girl, and if she is, I don't know whether you have to tell me if this pregnancy was of a lady who was mentally challenged and was in a legal relation with the man, or was she abused? There are two different aspects to this situations which generally are asked. So generally what is asked is a mentally challenged girl was raped. This is what generally happens. So who will give the consent for the abortion? So mentally challenged girl cannot decide, then the legal guardian has to give. But if this is a mentally challenged girl who is married to a mentally sound husband, then obviously the husband will give the consent. So there are some options which have to be provided to me in this question. So in this situation, mentally challenged girl, if it is just a mentally challenged girl and these are the choices, consent from the guardian or the parent, both B and C, they are the same choices. They are both are correct. Both correct options in this scenario, this question which has come. So if it is mentally challenged girl plus has a husband, I mean who is sound, husband who is of who is aware, who is sound mental status. If the question was like that, then obviously the husband gives consent. Then obviously the legal guardian doesn't come into play there. Husband's consent. Okay, so both the ways I have given the answers, and I'm sure all of you would have got that correct. What is written here? Parent, partner, legal guardian, both were there. No husband, no, वो examiner डाल देता है सर. अच्छा, so husband जाएगा. Okay, Mayank has given the full question, and I think in that situation, if it's a person who is in a relation, has a mentally sound husband, a husband who is able to take decisions well, so that must obviously the husband will give the consent for the abortion if the mother is not having a sound mental makeup. So that's the answer. If the question was the way I have given you, that this is a mentally challenged girl who got pregnant and there's no husband involved, I mean there was abuse of this girl, then the legal guardian will give the consent. This is a fairly simple question, depends on the, I'm sure all of you got it correct also. So let's not waste much time on this one. This was fairly simple questions. The whole paper I thought was simple, the way it was recalled at least. Okay. Husband का option ही नहीं था. Okay. Husband wasn't given. Then legal guardian. If husband was not given, husband consent, or next would be the parent or legal guardian. I think that should settle this. Partner was there. Guys, please decide. If partner was there, then that is the answer. Let's not waste too much time on this. This is fairly simple question, okay? This is more logical than gynecological here, because they're asking you a question which is so simple that if a woman cannot decide, the person who is taking care of that person will decide. And it has to be the husband. If the husband is not in the picture, if the girl is raped, then the legal guardian is there. Chalo, let's finish this question. I think this more than enough time wasted. Okay, chaliye. So let's do this one. This was a very simple question. Partner was there, na, so partner will give the answer. 100% partner was there. Shubham Sindhu. Yes, fine. Okay, partner is there. Partner is responsible. Partner got the lady pregnant, and the partner will decide whether they want to keep or not. If the woman is not able to decide for herself since she's mentally challenged. Chalo, 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 chalo. Bas, let's move on. So Amsel's criteria is used for the diagnosis. I mean, after seeing the fourth, fifth question which came to me, I was so happy that at least read the basics. And those who, I mean, how many forums I told you, live forums where we met across classes and all PrepLadder revision classes, and before the champions exam, the LRRs, I kept on telling you, at least read the notes by the 19 teachers whom you like. Can be any teacher, it can be any teacher whom you've been reading your 19 subjects from. At least read the notes and you'll pass your exams. And this is my exam, at least my questions, at least this 40 questions which have probably come to you, they look as the ones. If you've read the notes, you're going to just go ahead and sail through this exam. Okay, so yes, Amsel's criteria for bacterial vaginosis, there are 5 criteria and 3 or more if they are there. So 5 criteria like the alkaline pH, and if there is clue cells, and there is a fishy odor, and whiff test, and creamy white discharge. So I'm not teaching you all of this right now. These are the 5 criteria in Amsel's, and Amsel's will come, and we keep teaching you about that. And I told you that I've given you a chart where all the 3 infections were compared, and I told you that these are invariably coming in all the exams, and it came again in this exam. So please remember, Amsel's criteria, 3 or more out of these 5 they are present, then that is the diagnosis of trichomoniasis. Just a reminder, if any case, if any NEET aspirants are seeing this, please remember, metronidazole is the drug of choice. And even in pregnancy, if a woman is pregnant and she's got bacterial vaginosis, we can still give metronidazole. It's a safe drug. It's a category B drug. Can be given even in the first trimester if required, that is. Okay. Yeah, I don't know. 350 questions ho jata na. See, this question would have been taken by the microbiologist also. Pharmacology questions will be given to the subject and to the pharmacologist also. So you may get too many more questions than the ones have come. So yes, medicine is a continuous subject. You cannot say that there is just one particularly. So there'll be some core questions like labor, like there's a shoulder dystocia question that I only can answer, isn't it? I mean, I should be answering. I mean, I'm sure everybody in the world can answer. But I'm saying that yes, that is specifically for me. And then there'll be a question about lap cholecystectomy with my friend, which my friend Dr. Pritesh will answer. So specific questions will also come, but there'll be some overlaps. Liver disease in pregnancy, I'll also answer, and even Dr. Marwa will answer. So there will be overlaps. So don't worry. Okay. So don't worry about the number of times you have to see the same question. Chaliye. A pregnant lady, female is a bad word to use. A pregnant lady with asthma presents with hypertension, drugs used are. So basically means a woman who has got gestational hypertension or hypertension in pregnancy, and she's also having bronchial asthma. So which of the following drugs can be given for her treatment? So I would always say the drug of choice is IV labetalol in hypertension pregnancy. But labetalol is a alpha plus non-selective beta blocker. So that beta blocker action may cause problem in a patient with bronchial asthma. So that's why in the other drugs which are there, so labetalol, though both are out, ACE inhibitors cannot be given in pregnancy. So with the present choices given to me, I'll go ahead and mark nifedipine. So was methyl-dopa the choice there? Here the answer is nifedipine definitely. Blood pressure was given, okay. Recalls and exam में सब अलग अलग होता है निखिल सिंह. Don't break my heart. I'm standing here and trying to answer you what has come. So help me with the choices, my friend Nikhil. Don't discourage the whole session by saying recall is different from the exam which came. You're going to help us with the questions, right? So you're here to have a discussion. I'm sure you've done a good exam and I'm sure you're going to pass, but help your juniors also pass this exam. So please give us the best choices which have come. That's the session is to meant to get the best answers, best choices which came in the exam. Chaliye. Exactly same. Okay, Nikhil. There are some people who are contradicting you. All right. So here the answer cannot be labetalol. I'll go with nifedipine. You can give methaldopa also. So yes, the drug of choice always is labetalol, but the previous drug of choice was methaldopa. That doesn't interfere in any patients with bronchial asthma. And even before that, much earlier than that was hydralazine. So look at these options. If you cannot give labetalol and if labetalol is not in the choices, then look for methaldopa next and then look for hydralazine, look for nifedipine, and nifedipine was here as the answer. So that is a good answer here. Let's move on to see question. So labetalol is the first line drug. It's alpha plus non-selective beta blocker. This I've got it from my app. And this is what we've given you as the information. Since it has this non-selective beta blocker action, it is contraindicated in asthmatics. So just reminding what we taught you in the app. Right. Falciparum malaria, what is the drug used in pregnancy? Yes, that's a good question. Yes, medical disorders in pregnancy, like I said, I'm sure the medicine people are teaching you this and I'm also teaching you. Maybe the pharmacologist will also come and play here. Tell me now. IV and labetalol, both I won't give. Both will act on the same receptors, my friend. So IV labetalol will probably call an acute exacerbation of symptoms of brachial asthma. So prevent. I mean, you can give IV hydralazine. IV hydralazine is excellent drug. IV hydralazine can be given. And oral nifedipine can reduce the blood pressure in emergency. That's fine. So it's okay. Both ways I will not answer labetalol. Oval was given. And chloroquine plus primaquine was the options. Primaquine is there. It is there in the options. I'm not saying this is the answer. I'm just saying quinine, primaquine. Was chloroquine not there? Was chloroquine not in the options? Acha, Vivax came. It was not this one. It was Vivax. All of you agree? Resistant malaria in pregnancy. Guys, now decide what was asked. Was it falciparum malaria or was it Vivax? So for all these confusions, turn to the next slide and all the answers are here for you. So treatment of malaria in pregnancy, I knew that there will be some confusion invariably. So I got this slide for you from the app. Remember that uncomplicated malaria, drug of choice for malaria in pregnancy, go ahead and mark chloroquine as the best answer. So yes, Vivax, Malaria, Oval and chloroquine sensitive falciparum, all you will give chloroquine. Okay, that's the answer. Now, when we are giving this postpartum, after you give this chloroquine or hydroxychloroquine, after delivery we give the primaquine tablets. Now, what happens when a patient has chloroquine resistant or multi-drug resistant falciparum malaria? So the first management here is artemether and lumefantrine combination. So these are all artemisinin group of drugs. This artesunate or artemether, these are all artemisinin group of drugs, and that's why these are excellent drugs which are given for patients who have got resistant malaria. And similarly, if there's a falciparum which is resistant to all other drugs, please, falciparum, we generally, if we know it is falciparum, we actually bypass all the drugs, we go straight to artemether and lumefantrine combination. So that's why I gave you this. And when there is a chloroquine resistant falciparum, chloroquine resistant Vivax infection, then we'll say give mefloquine. So look, if what was the question? What happened in PSM? I won't be able to answer right now. It depends. Treatment of, okay, somebody's writing, is Ali is writing the question. Treatment of Plasmodium vivax in pregnancy in first trimester. Look, Plasmodium vivax in pregnancy in the first trimester, the answer is completed here already. That's as simple as that. Okay, so it's such a simple question, then I don't know why the recall which came to the team PrepLadder was so complicated. So please, if it is Plasmodium vivax treatment, that's all they've asked. They've not asked resistant, they've not asked falciparum, they've not asked this. Then the drug of choice is chloroquine. There's no doubt about that. Not quinine. Quinine is quite toxic. So yes, we can give quinine, but the drug of choice is chloroquine. Okay, so if that was the question, Vivax ही था, second man pregnancy था, उसको Vivax था. Fine, I agree. All right, guys, I agree totally with you, and we are not going to change this question. Chloroquine plus Pramaquine. No, I will first try to give only chloroquine and not Pramaquine. Okay, chaliye. Right. We are not going to discuss this much more because what came in the exam was finally given to me. If it was Vivax, then chloroquine is the drug of choice. Simple question they asked you. Now, question number 6. Yes, anything else? Only chloroquine was not in the option. Look, there is a lot of variation in the recall which you're giving me even here. So that's why these confusing answers come out from us. So we'll just go back and tell you that if it is only chloroquine, then that's the answer. And if chloroquine and Pramaquine was given and it is first trimester, then obviously what the PSM teacher told you is correct. Then you have to go ahead and give quinine. That is what is the best here. But better than quinine, I would still think in terms of giving artemether, because that is what is much safer. Okay, so artemether can be given with much more safety as compared to quinine. So yes, I will say Vivax, go ahead and give chloroquine, and other things I've already given you, and I will say that till you give me the better complete choices, we'll hold back our discussions and go to the next question now. So yes. Now, I mean, if there is no other option and there was quinine given and the other choices were all combinations, then we'll go with the safer drug. And quinine is it's quite toxic. The toxicity is of the tablet itself, but it's not having a problem on the fetus. So then it is safer than the other drugs. So yes, that way quinine could be the answer depending on the choices which came. Okay, now young lady with unprotected intercourse came to OPD after 5 days. Most likely contraception used. I mean the best contraception which can be given. Pardon the language here. So yes, tell me, what can you give when a lady came to you after 5 days? So when a person comes for emergency contraception, best is given within the first 3 days. And after the first 3 days, if the lady comes, then the definition is for 3 days. And after 3 days which comes, we can prevent implantation, because implantation happens after 6th day, on the 6th day rather, after suppose a woman has intercourse today, earliest implantation can happen is on the 6th day. So yes, till 5th day we can prevent implantation, and that drug is IUCD. So yes, after this option which has been given, she's come to you only after on the 5th day, then you have nothing else but to give IUCD. And this answer I'm sure all if you marked IUCD, because that's the only one which can be used with good effect till 5 days. Till on the 4th and the 5th day, IUCD can be used. Even Uliprastal can be used, but I have not heard that it's still been approved by the government of India for the purpose of emergency conception. So that's not also in the choices. So we'll go ahead and mark IUCD the answer for this one. Okay, on 5th day third, tick answer. Okay, tick the answer. Okay, fine, I'll tick the answer. So I would say in this the question here which we are discussing, the answer is IUCD. All right, that is the answer. Okay, chaliye. Condition where both male and female partners should be treated together. Now that's a very simple question here, that the answers are all of the above, all of the ones which are given here, because I don't know what came as the choices. I'm sure they want to tell you about trichomoniasis, which is the answer here, but you're very sure, and I'm sure that all of you know that if a patient has syphilis, you have to treat herpes also. If it is the infective stage, then you have to treat both husband and wife. And candidiasis, it's better you treat the male plus female partner both. Yes, candidiasis, we all know it is not sexually transmitted, but fungal infections can be transmitted because of proximity. And if a partner is staying together, I mean, these partners are living together, obviously, and they're using the same beds and the bed sheets and the towels and the, the proximity will have fungal infections. So they always, medical books also say that it's better if a person has candidiasis, then the partner is also treated. Also not very strictly. So if there is only one answer, go ahead and mark trichomoniasis, because with one intercourse, if the woman has trichomoniasis and one intercourse with the partner, there's a 70% chance that the man also will get infected by trichomoniasis, 70% chance. So this answer straight away, if there is a single answer and this was the language, you'll have to go ahead and mark trichomoniasis best. Syphilis is not given, okay. Bacterial vaginosis, the syphilis was not in the choices. Bacterial vaginosis was there in the choices, not to be treated. Okay. Treatment of partner is mandatory was the language of the question. Okay, we'll go ahead and mark trichomoniasis. Fairly simple. I mean, so far the questions are simple, only the choices between you and me are getting complicated. The questions which have come in the exam are fairly simple. Chaliye. McRobert maneuver failed in shoulder dystocia. What is the next step in management? I hope this was the language. Anybody else? Anybody wants to tell me about this one? Yes? Anybody else feels different? Because we always say first do McRoberts maneuver. Whenever I face a case of shoulder dystocia, first thing is that I'll tell the nurse to, push back the legs of the lady, and the nurse will help my intern friends, they are you guys are going to be helping me in next 3 months, that you're going to be coming and helping us when you hold the legs of the lady, because she's too tired to keep her legs too up. So one intern this side, another intern this side, or the nurse will hold the legs up, and that is going to cause, the flexion of the hip joint more than 90 degrees. So that flexion of the hip joint will increase the anteroposterior diameter, and the shoulder will, this head has come out and the shoulder is not coming out. So this flexion of the hip joint will cause the disengagement of the anterior shoulder easily. So that's why McRobert maneuver, immediately that's what we do. And another doctor will come and give us suprapubic thump, one suprapubic pressure. So suprapubic pressure is the next thing to do. So I'm sure all of you got that correct. I mean, those who attended my classes, I'm very sure. Rather than remembering too many mnemonics, you should remember things practically. Sabse pehle, go ahead and do McRoberts maneuver, and after that we go ahead and give the suprapubic pressure. Options were different. Internal rotation, release of posterior arm. Okay, internal rotation maneuver was one of the options. Internal rotation, see, internal rotation is not rotate the baby. You rotate hold the shoulders and rotate the shoulders. That is what is the Wood's corkscrew maneuver. See, the anterior shoulder is stuck under the pubic symphysis. So turn the baby by 90 degrees so that the anterior shoulder comes from the posterior vagina. It comes out from the posterior vagina. And then you turn the baby back by 90 degrees, and then the second shoulder is also delivered from the posterior vagina. So it is called the Wood's corkscrew maneuver, or also known as the internal rotation. But actually when you say internal rotation, you're talking in terms of turning the baby. Or when the head is outside the vagina, how can you do internal rotation? Turning the presentation of the baby by putting your hand inside is internal rotation. So that is not what is meant in shoulder dystocia. I doubt if that was the option. I mean, that option is also so vague if they have given you that. So Javanelli is the last thing. वो तो कभी भी नहीं answer आएगा. Javanelli is the last thing to do. Option very different. Options were pull shoulder, pull posterior hand, internal rotation was one of the option. Internal rotation was one option. Okay, ठीक है, internal rotation नहीं करना. अगर था option, so I mean, if it is there as the option, please don't go ahead and do it. Don't do the internal rotation. Option were there. Suprapubic pressure was there as an option. Let's say Weber. What do you say, Weber Sharma? Was there an option of suprapubic pressure? Then that is actually the easiest next step. So don't get worried about that. The internal rotation we can't do. If there was the option, I'm not worried about. Suprapubic was there in the option, go ahead and mark. Internal rotation is done for, like external cephalic version is done for what? External cephalic version is done for, suppose, I'll try to help this with this bottle here and show you. So if you see this bottle here, so if this is the breech and this is the head. So you don't want a breech to deliver, so you do external cephalic version. Now, when a patient has transfer like we do internal podalic version. So we go inside and hold the leg into internal podalic version from the vagina in the second stage of labor, that is after the first of the twin is delivered. Second is in transverse lie, we can do internal podalic version. Now, what is internal rotation? Okay, so internal rotation is turning the baby, trying to turn the baby and trying to get the anterior shoulder delivered from the posterior vagina. So that is in fact what is called the Wood's corkscrew maneuver. So I hope if Wood's corkscrew was not there, so internal rotation could be the substitute choice given for Wood's corkscrew maneuver. Wood was not there, so ठीक है, I will write internal rotation here as the option. Chalo, I'll write that for you. Still the answer is suprapubic pressure. Somebody asked me to take the answer, so I've taken that for you. It was breech presentation. Breech to nahi tha yaar. Shoulder, question was shoulder dystocia. Don't change the question altogether, please guys. What is there? Was the question shoulder dystocia or breech? Come, don't change the question altogether. Ali is talking like me. He's saying, sir, instead of wood, they gave internal rotation of the head. I don't know. Internal rotation of the head. Now somebody is putting a doubt, sir. Question was breech. I think by the time we come, if this discussion was done after 1 week, you'll say, obs ke question, we'll start recalling surgery. यहाँ पे तो question इतने तुम लोग गड़बड़ कर रहे हो. There's so many things you're mixing up. Shoulder dystocia tha na? Right. Guys. All my Hindi speaking friends and my Tamil speaking friends, guys, shoulder dystocia இருந்தா இது உங்களுக்கு ஆன்சர் மூணாவது ஆன்சர் suprapubic pressure. அவ்வளவுதான். சரி, அடுத்து பாருங்க. Question number 9. A woman who has done strenuous exercise complains of involuntary urine escape during her workout. What is the diagnosis of this one? Yes. After McRoberts, we do Wood's corkscrew. No. After McRoberts, we do suprapubic. And if suprapubic doesn't work, then we try Wood's corkscrew. And then actually we try everything which is there in the book. So generally the first two we know. First two we say, first is McRoberts, second is suprapubic pressure. And then you start praying very hard to the Almighty that help, this baby has to survive. So then whatever comes to your mind you do. So there is not that after that you should do this and you should do this. Aisa karke, there are no strict protocols. Yes, there are a lot of mnemonics given in your, so many recall sessions in so many places you've seen. But yes, what is very sure, first is McRoberts, second is suprapubic pressure, and after that you can do Wood's corkscrew and you can do Gaskin, which is on all fours. You make the woman be on a knee chest position, that is known as the all four maneuver. There are many maneuvers. Last is definitely last, and which is the most traumatic, is to put the head back into the vagina and make an incision on the abdomen under anesthesia and take the baby out by Javanelli's restitution. That is definitely the last. बीच में बहुत कुछ और होता रहता है. All right. चलो छोड़ दो. Let's go to this question. Strenuous exercise and complaints of involuntary voiding of urine during workout. Yes, it can happen with infection, but strenuous workout, I would still think in terms of stress urinary incontinence as the first thing. Yes, they have not given me whether it was a pregnant lady, because pregnant lady I would have thought in terms of more of infections, because pregnant women will have some laxity of the vaginal muscles and the pelvic muscles, and that along with the minimal amount of infection also can cause some escape of urine. So those things do happen to pregnant ladies. So especially when the pregnancy is a little advanced. So all those things, in pregnancy which we see, those can be seen. But if they asked a woman who is doing a strenuous exercise and urine escapes, go ahead and mark stress urinary incontinence, because the bladder angle, which is normally something like 85 degrees. So that straightening of the uretrovesical angle, this angle which is around 85 degrees becomes more than 110 degrees. So that is what is going to cause the patient to have straightening of the bladder and the urethral. So this is, if I try to show you with a simple demonstration here, that is the bladder and this is the urethra. So this is the usual angle of the bladder and the urethra. Every time the woman coughs, the pelvic muscles, especially the pubo rectalis and the pubo-vesicalis, will lift up the bladder neck. So when a woman coughs, it's like this, like that, like that, the bladder neck will get pulled up. But if it is straightened like this, every time she coughs, the abdomen compresses, abdomen pressure increases, the bladder compresses, and the urine escapes because there is a straightening of the uretrovesical angle. So I'm sure the answer is stress urinary incontinence here in the scenario which you've recalled things from. 80-year-old female, yeah, go ahead. 80-year-old female doing a workout, a strenuous workout. Yeah, you guys are troubling me now with the choices. 80-year-old woman doing a strenuous, 80-year-old woman walks and coughs a little, she'll have stress urinary incontinence many times. If she's doing a strenuous workout, please tell me the choices properly. Answer is stress urinary incontinence by whatever you guys are trying to tell me, okay? Okay guys, 70-year-old हो गया अब जल्दी से. 40 years हो गया. You guys, I think let's move on. Question number 10. Woman fainting while lying down feel better while sitting. Now, it has to be a pregnant woman here. Has to be a pregnant woman. Then only I am part of the question. Otherwise, a normal woman sitting and feeling, having dyspnea and she's better on lying down, then I have to think of all the cardiac lesions which I last did in my MBBS. So maybe aortic regurgitation would be something like that. So guys, please don't test my knowledge of medicine because it's not existent. So let's come to obstetrics. Pregnant Tana, thank you so much. SVC was a pregnant woman. Okay, fine. Thank you for reassuring me that it was a pregnancy. So yes, the big baby will press on the inferior vena cava and that will cause the supine hypotensive syndrome. So that is what is the reason. So that's why pregnant ladies must be not sleeping supine. Pregnant ladies must be sleeping on the left lateral or the right lateral position, preferably left more than the right. And both are correct actually. Left better than right, that's what I'm saying. And when the person is lying down straight, then there's a 10% of such women can have venous compression. The baby will press on the inferior vena cava, the venous return to the right heart of the mother will reduce. So the cardiac output eventually will reduce, and that reduced cardiac output may not be very harmful for the mother, but it will be detrimental for the fetus, can even cause hypoxia to the fetus. All right. Similarly, even when we're doing a cesarean section, we'll have to think in terms of doing them the cesarean section not in a total supine. The lady should be a little tilted towards the left. A little tilt towards the left is given while we're doing the cesarean. A wedge is put under the buttocks of the lady. That's how I do my cesareans. I mean, we don't put a wedge. Mostly what we do, we put a IV fluid bottle under her bum. So that will make a tilt required amount. So the correct answer is superior vena cava. No, inferior vena cava compression. Okay, I marked the answers. Suprapubic I marked. Okay, fine. Chalo. What else are you guys asking me? Uterus pressure increase, IVC compression, pregnant mother, and SVC not in the option. Okay, fine. I think more or less you would have got this correct. This was a simple question. After lunch was the option. Lunch के बारे में क्या लिखा था? Yes, anybody having lunch, you and me also, after lunch, if you have a discussion about the questions which came in obs and gynae, then only 225 students come. If this was before lunch, then probably 300 would have come, or more than that would have come, because after lunch everybody wants to sleep. Why? Because when the gut gets distended, more blood supply goes to the GI system and the peripheral flow is reduced, and that's why when the flow is reduced, you feel a little cold and you want to rest and you want to go and sleep. Isn't it? Because circulation to your brain also reduces a little bit. So you feel like, let's go and take rest. So that's why the best thing in winters is have rice and dal and have some pickle and papad and go to sleep for 2 hours in the afternoon. You know you're going to get that because you're going to be interns in 3 months and you're going to be working with all the rajma chawal in your tummy, right? Come, let's come here. Option was lunch. Chalo aage badhte hain. Folic acid therapeutic dose is given for 4 milligrams per day. Okay, so the requirement is 0.4 milligrams and the replacement is 4 milligrams per day. But yes, some books say 0.5 is the requirement and 5 is the replacement. Okay, so that's all right. So it's given for people who have neural tube defects or a mother who's on antiepileptics, things like that. So I don't know what are the choices here. But these are choices. It's like, what these are choices? Diabetic option was not there. Sickle cell anemia was the option. So premature delivery, preeclampsia, previous low birth baby are not the indications. So probably in sickle cell anemia you can think, because these are all high risk pregnancies, and of course there is a problem in the formation of but the hemoglobin chain is bad, but supplementation of folic acid is not going to change things in sickle cell anemia. So I don't know whether this was the answer here, because if you say sickle cell anemia, it automatically becomes the best choice amongst these 4 choices which you have told me. But I don't think that will be the very the best answer which I can think of. Anomalies, antiepileptics, these are the choices where I was expecting. Previous history of abortion was there, then go ahead and mark that. That is a much stronger indication. Diabetes was there or not there, it is not an indication. Leave diabetes alone. Yes, if diabetes is there, diabetes itself is not the problem, but diabetes can cause congenital anomalies. So that way it becomes an option, because see, a lot of you are saying diabetes was not in the option. So if diabetes was there and sickle was there, then I'll go ahead and say, you're saying diabetes not there, instead of diabetes sickle cell was there, then I don't know why, but sickle cell anemia could be the answer. I'm not very sure how it is going to help, I'm telling you frankly. But if sickle cell anemia is there and diabetes mellitus is there and previous low birth weight baby is there and previous preterm labor is there, then I'll go and mark diabetes. Why I'll mark diabetes? Because diabetes is associated with anomalies. That's why. Otherwise, diabetes per se does not require this supplementation. Diabetes in the first trimester can be associated. Then obviously that's the answer. I would have answered diabetes, because in when this question came with these 4 choices, I would have answered definitely diabetes, because all these 4 choices did not make very good sense. The only option was diabetes. But you said diabetes was not there and sickle cell was there, then I'm totally lost. So yes, now you tell me. Yes, diabetes. These are the options which I've written. These are the options. Impaired glucose tolerance was there. एक ही बात हो गई. If it is impaired glucose tolerance, then it may be associated with anomalies. So if it may have anomalies, go ahead and give Fmge or as a supplement dose, not as a replacement dose, not as the daily dose. So yes, in this 4 options, these A, B, C, D, then B is the answer. All right. Okay, chale, let's go on to the next one. डॉक्टर राणा इज सेइंग ये तो क्वेश्चन ही याद नहीं आ रहा यार. कोई बात नहीं यार, अब तो तुम पास हो गए, तुम्हें याद क्या करना है. यू रीड फॉर द नेक्स्ट एग्जाम नाउ, यू आर ऑल पास, डोंट वरी. चलिए, क्वेश्चन नंबर 12. कर्डी वाइट विजाइनल डिस्चार्ज विद सूडो हाइफे. हाइफे लिखा हुआ, हाइफे. Okay, curdy white discharge. I mean, there is this one question which you know the answer even only because you attended MBBS. I mean, whether you went to the class or not, we don't know. So you've done MBBS, you know this answer. Curdy white discharge, go ahead and mark candidiasis. So इससे easy question आपको national board वाले, I mean, they cannot ask you. थोड़े easy question भरा दपा, हाँ? इनमें easy भरा दपा. Please, that's why I said no. This is one very good exam for you guys to just make sure that you get all gynae questions at least correct. From my side, it's looking like a very straightforward kind of a exam so far. Kelly, I'm not wasting much time on this. There is a discussion about whether Candida is a dimorphic fungi or not, because we gynecology say it's a dimorphic fungi. So I got you the book which says that, and that is Novak's Gynecology. This is not me. This is Novak's, and Novak's is the Bible for us, the ultimate reference book. So I took the the courage to get you a printout, a picture of the Novak's, and it says that. Candida are dimorphic fungi existing as blastospores, which cause the infection, responsible for transmission, asymptomatic colonization, and as mycelia, which result from blastospore germination, enhance colonization, and facilitate tissue invasion. So basically, spores cause the infection and mycelia cause the invasion. Now, there is another thought of people, we say that they don't have true hyphae, they have pseudo hyphae. So yes, that also is something which a lot of people say. And if there is pseudo hyphae and cardiovaginal discharge, still the answer is candidiasis. So yes, there is some controversy about whether to call it a dimorphic fungi or not, or it call it a yeast-like fungi. So that controversy, this is not the forum to discuss. Probably me and the microbiologist who is taking your classes will come together with a joint session and come to a conclusion what has to be taught to you guys for the purpose of microbiology. All right. Okay, primary Candida came to the emergency room at 1 p.m. with 5 centimeter dilated cervix and at 4 p.m. with 6 centimeter dilatation. That means from 1 p.m. the partogram has gone into 4 p.m. that is 3 hours, 2, 3, 4, that is in 3 hours. In 3 hours, cervix is dilated 5 to 6. It is dilated 1 centimeter. So this is obviously poor progress of labor. What we expect in pregnancy, in labor, in active, since it is 5 centimeters, so 4 centimeters and beyond. After 4 centimeters, we say it is active stage of labor, and then in active stage of labor, I expect 1 centimeter per hour dilatation and 1 centimeter per hour descent. Both should be 1 centimeter each. So that's why in active stage of labor, if this is not happening, then we see if the contractions are good or not. Because if there are not good contractions and the cervix is not dilating and the head is not coming down, increase the contraction. See that there should be good contractions. What are good contractions? There should be at least 3 contractions in 10 minutes, and those each of these 3 contractions should last at least 45 seconds. So 40-45 second contraction coming once in 3 minutes is good contraction. If that is happening, then the labor should progress properly. So if poor contractions, we will be marking that in the partogram. If the partogram is showing poor contraction, then increase the oxytocin. And if it is, if this situation is, if with good contraction, if there is a good contractions and there is no progress of the descent or the dilatation, then we say do, that is a probably a big head in a small pelvis. So do a cesarean section. So this is what has to be done. I mean, if there are no, I mean the contraction is not good and the cervix is not dilating like this picture which has come, then you increase the oxytocin. But if there are good contractions and the head is still not going inside, then probably the head is too big for this pelvis. There is a cephalopelvic disproportion. Then you may have to do intervention, which is obviously a cesarean section. So what were the choices and what you guys are saying? So ARM and wait and deliver, no, not at 5 centimeters. No, ARM, acha, that, oh, you were saying those were the choices, acha, choices were those. Okay, fine. Option was do ARM and check after 1 hour. Yes, that is a good thing. Either you increase the oxytocin. See, I don't know what was the complete language of the question. If the contractions are not good, then you either increase the oxytocin or you do an artificial rupture of membrane. Both are known to increase the contractions. So yes, that's what I said. If poor contractions increase oxytocin, or if ARM is not done, do an ARM. ARM is done. Okay, you can increase oxytocin or do ARM. Both are methods of augmenting labor. But mostly in labor rooms, nobody is going to leave a cervix. I mean, nobody is going to leave a bag unruptured in active stage of labor. That's what happens in practical obstetrics, because everybody is worried about meconium straining of labor. So mostly in active labor, we do ARM so that the patient delivers fast. Although it's not a very good habit, but yes, doing an ARM, you know what kind of liquor is there inside, and that also is a good method to increase the contractions, and also is a good method because at suppose 5 centimeters I want to assess the baby, I can make a small nick on the head of the baby through this cervix and get minimal amount of blood and do the pH of the baby to see if the baby is getting acidotic. So ARM is mostly already done when such questions come to you. They would have already done it. But if that was the option, I mean, if the question was saying there was no ARM done and the option said do ARM, means the same. Either give oxytocin or ARM to increase the contractions. So let's see. What is the slow progressive labor? That is the diagnosis. So that's not the answer. Wait for complete dilation. No, I cannot wait. This cannot be the answer. This cannot be the answer. Induced labor, she is already in labor. Intervention to be done. That's the only sensible answer to these, I mean, to this question in these 4 choices given to me. And what is intervention? I will told you that if there are good contractions and the head is not coming down and the cervix is not dilated, I go and do a cesarean section. One ARM plus delivery, second was ARM and oxytocin plus delivery. Okay, fine. That I think ARM and oxytocin plus delivery is a good answer if the contractions are not good. ARM and oxytocin was there, na? That's it. That's the answer. Then that's the answer if that was the choice. See, the choices given to me, intervention is the answer. What is intervention? ARM and oxytocin if the contractions are not good, and if the contractions are good, do a cesarean. Simple. Understand this? I'm sure all of you would have anyway got the answer correct. Fairly simple question. I mean, like, not because I'm an obstetrician and thinking this way. I'm sure all of you will also think that way, because this much everybody knows that in labor, at least 1 centimeter dilatation and 1 centimeter descent should be there in active labor. That is not happening. You understood the language immediately after you read the question. So you got that correct, I'm sure. Primary 8-9 hours labor at 1 p.m. with 5 centimeters dilated, and 4 p.m. 6 centimeters dilated with good contraction, and the option was spontaneous delivery. No, can't wait for spontaneous delivery. 8-9 hours of labor. Labor should not be more than 6 to 8 hours. 8-9 मतलब upper limit 10 घंटे 12 घंटे जो बोलते हैं, that patient is reaching there, and the contractions are good. Then you're answering yourself. You're saying do a cesarean section. So either way I've given you. Let's move on to the next question. चलिए, match the sequence. यार ये तो ना question, read till here. I don't know the choices also which we came. Okay, anyway, tell me what were the, was this a question? Lactogenesis, mammogenesis, galactoporosis क्या होता है? I don't know. Galactopoiesis, I know. I was asking the pediatric faculty also if she got this question, but unfortunately the question has been recalled only to me. Whether PSM people got this question, I don't know. So lactogenesis, mammogenesis, galactoporosis or poiesis, and galactokinesis. Were these the choices? First of all, let's discuss that. Yes, there was a question like that. Okay, fine. Galactopoiesis ही होगा ना यार. Galactokinesis and galactopoiesis makes sense. Yeah, galactoporosis, I don't know what is galactoporosis for the first thing. I've not heard of galactoporosis. Osteoporosis I've heard sometimes. Lot of times, okay. Galactoporosis, I don't know what is that. Obviously, yeah. I just got the questions, man. I mean, please, guys. So, galactopoiesis हो सकता है, yes. That is the process of, you know, the development, yes, development of the milk production. So, yes, I will go with, this looks like a good choice. The one which is saying that mammogenesis, genesis ही नहीं है, genesis है, lactogenesis, galactokinesis and galactopoiesis. Because mammogenesis has to be first, yes. Right? Formation of the breast, the development of the breast for pregnancy. The pregnancy should have a good development of the breast, the growth of the breast size, and the development of the ductal system and the glandular system to accommodate the milk production. All that happens first. Right. So we'll stay with C till the best answers, best choices for this question come to us. Right. So Turner syndrome, fairly easy question. Turner syndrome is something which all of you are prepared all your life to answer. And we always tell you that Turner syndrome, we teach you, we tell you that please don't forget Turner syndrome. That's the most common cause of primary amenorrhea and the most common cause of, most common gonadal dysgenesis also. So yes, web neck, which is seen, except here, which is seen Was it accept or seen? Because I don't know this COA is coarctation of aorta. Coarctation is seen. Wide chest nipple, wide widely spaced nipples. Because they look widely spaced, probably because the breast development is not there, so they look very distant. And widely spaced nipples and coarctation of aorta, webbing of neck, and low set hairline. After that, patient having cubitus valgus. Was cubitus valgus a choice? Cubitus valgus. Somebody just before the session started sent me that cubitus valgus was a choice. So yes, except नहीं था. What is there था? अच्छा, what is there? Coarctation aorta was not in the choice. I'm not striking out anything. Let 15 of you say that coarctation was not there, then I'll strike it off. Wide carrying angle, huh? Cubitus valgus is wide carrying angle, means the same. Valgus is, this is like we stand, so this is valgus. When the hands are like this, it is valgus. So this is a carrying angle. See, from the waist of the lady, this angle, this one is a carrying angle. So this is wide carrying angle. Yeah, that's fine. Wide carrying angle or cubitus valgus means the same. So cubitus valgus is seen. Obviously, cubitus valgus is seen, and so is webbing of neck. So was webbing of neck in the question or in the choices? I don't know. Was Turner's in the question or the choices? So a lot of confusion, guys. You have to tell me, was the question on Turner syndrome or on web neck? चल छोड़ो ना. Somebody is saying, Pratik Pagar is saying, sir, web neck Turner syndrome mark कर दिया, sir, आगे चलते हैं. Good. I like people like Pratik. चलिए. Question number 16. 22 weeks ultrasound shows a marginal placenta. Reassessed by ultrasound at what gestation? I assume that was the question. I told you that when there's a pregnancy in the beginning, when there's a pregnancy which is showing a placenta previa partly covering, and then later when the uterus becomes big and the cervix becomes effaced a little, then this placenta, with the increasing in size and with the effacement, the placenta may move onto the side. There might be a apparent migration. It's not that the placenta is migrated. It's not the placenta is climbing the uterus. No, placenta is stuck where it is stuck. But what is happening, that the placenta was partly covering the os. Now the uterus increases in size and the cervix, like I keep showing you with my hand, cervix effaces. So if the placenta was, if it was covering the internal os, and with the effacement, you see the placenta moves on the side. So the placenta has probably moved on the side. That can happen. So when do you want to assess that? We assess that at term. So the only question which is coming here, only choice which is coming here close is term. So at term we repeat the ultrasound. All right. Chaliye, let's move on and see the next question. Covering the os tha. Treatment LSCS tha. I don't know whether that was a question. Okay. Yes, okay. Harsha is saying that there was a question which there was 22 weeks, there was a placenta which was covering, and what can be done? So reassess later at term. Right, that is precisely. So reassess at term is the best answer. So all of you got that correct. Now, gold standard for diagnosis of endometriosis, fairly easy one. I hope all of you got laparoscopy correct here. Nuchal translucency, what was the question? You must tell me, because I don't have any question on nuchal translucency. But yes, it is done around 12 weeks and more than 3 millimeters is bad. So whatever was asked, it's a screening for aneuploidy. You know that very well. So fairly simple questions have come. Anyway, so I must not go on pushing this session, because you have to get answers from Dr. Pritesh, who is in waiting. So please tell me if there is something else which you want to discuss. Tell me. Nuchal translucency chhod do. We are discussing in terms of gold standard for endometriosis. Answer for this one. Gold standard for endometriosis diagnosis, that is laparoscopy. Better answer would have been laparoscopy plus histopathological examination of the lesions. That is even a better answer. So just the histopathology is not good, laparoscopy is the best. Along with that, if you combine histopathology, so in this I will go and say laparoscopy. All right. 11 to 14 weeks and nuchal translucency is the answer. That is correct. Okay. Ovarian torsion, what is the investigation of choice? Probably the radiologist also would have taught you about this. So when you see the uterus and when you see the ovary, ovary is attached to the uterus with the ovarian ligament. This is the fallopian tube here. But yes, the ovary is also suspended to the pelvic wall with the infundibulopelvic ligament. So what happens when the ovary undergoes torsion? So since there is a dual blood supply, there will be some blood coming from this side, there will be some blood coming from this side. So when the ovary undergoes torsion, what happens? The arterial blood supply is mostly maintained even in a torsion because there is a dual blood supply, but the venous return will reduce immediately of the ovarian vein. So yes, the ovary gets enlarged and the venous return stops. So on the Doppler, yes, on the ultrasound plus Doppler, we will see stop of venous return and enlargement of the ovary. This is what we usually see. All right. So what are you guys saying here? Right, all sound in Doppler. That's a fairly simple. At least here we are. Last few questions, the controversies have reduced. The number of discrepancies have reduced. So which part of the placenta is attached to the maternal body? Yes, when we talk about the maternal body, yes, if you look at this picture, I hope some things will get clear. So the sac, gestation sac is like this, placenta is attached here, and there is a fetus here attached with the umbilical cord. So there is a decidua here and there is a decidua here. So the decidua here is decidua basalis, and this one here is capsularis, and this one here is parietalis. So yes, the one which is in touch with the mother's body, that's what was the question. Yes. Maternal part of placenta is derived from was the question. Oh God, I went and taught you so much about the types of decidua. Maternal part of the placenta was derived. All right, decidua basalis again. Right, but again, if you give me better choices, it'll be. But yes, if the question was, see, chorionic plate basically means this the chorion, the size of placenta. The chorionic plate is big or small, like that we talk. So that basically means that. So spiral arteries is not the spiral arteries. What is supplying, giving blood in the placenta. So the villi will come into this pool of blood and suck out the nourishment for the fetus. The villi will come into this pool of blood which is given by the spiral arteries. So yes. Which question is correct, Hari? The one which I am reading? So answer is decidua basalis then. Right, Hari, thank you for that. Multigraduate with previous cesarean section. Which of the following is the best for vaginal delivery? In which of these we can do a, I mean the choices are very vague, the ones which came to me. So please help me with the choices. And I think yes, there are a lot of questions which I don't have the the choices properly. So yes, let's quickly finish this now. I don't want Dr. Pritesh to go on waiting for the sessions to finish. Prolapse में आते हैं हम लोग. Can you just tell me the choice for this one? Multigraduate with previous cesarean section. Which of the following is the best for vaginal delivery? Previous cesarean section breech we cannot have. Vertical cesarean section, you mean to say vertical abdominal, or did they mean classical cesarean section? Did they mean classical by this choice? So if it is vertical incision on the uterus, was that the meaning? See, if there's a previous LSCS and the patient has hypertension in this pregnancy, I can give a normal vaginal delivery. So, the answer to this question in my mind immediately was this one. Now, you can deal with other choices if you want to vary with the, what else was asked in the exam type. क्लासिकल था ना चॉइस फॉर, तो क्लासिकल में तो हम नहीं कर सकते हैं. Transverse cesarean section. What is the meaning of that? Transverse means there's an incision which was transversely given on the abdomen or on the uterus. So there are a lot of things which I need to know about this question. That's why I'm saying classical cesarean section was given as the option. Can't do for normal vaginal delivery. A transverse cesarean section, classical cesarean section, preeclampsia. Don't remember. Okay. Low risk for VBAC. Oh. So, low risk for VBAC is then the answer is this. So, the question which came to me, the one which I was seeing on the screen, answer is C. Now, if they say low risk for vaginal birth after cesarean section, then it is for transverse uterine incision in lower segment. Then I will mark this. Okay. So, we have discussed both the options, both the possibilities if this was the language. Right. Uterine inversion, what is the management? My team does not know the choices, so they send me like this. So, uterine inversion, the first thing is we give the patient pain relief and we sedate her, and then we remove the placenta. Remove the placenta and do a manual reposition. So, yes, remove placenta, pain relief I am writing first, remove placenta, give terbutaline to relax the uterus, then reposit the uterus, reposit manually, mostly that is what we do, and once inside, once back, once the uterus back inside the body, give patient oxytocin to contract the uterus. Chalo, alright. I don't know what were the choices. Manual reposition. The manual reposition was option like anterior fornix, presence of vasopubius. Manual replacement. Yeah, manual replacement was there. Then go ahead and do that. That is the best. Manual was given. That's fine. This is the way we do it. Push back inside. This is generally done by manual reposition. Mind you, with inversion, the woman dies with, yes, neurogenic shock because of the pain and hemorrhagic shock because of the bleeding, and more commonly because of the bleeding. Hemorrhagic shock is the most common cause of death in the case of inversion of the uterus. Right, diabetes in pregnancy, screening amount of glucose used. Yes, now that's the one which is the easiest question you guys were hoping you'll get in exams. So, GTT is done after 24 weeks of pregnancy, and that is done with 75 grams of glucose, and that's why it's called the one-step test. That's why it is called the one-step test, because you just do one test, that is you give glucose 75 grams. So, fasting should be, yes, fasting should be less than 92, and 1 hour should be less than 1 hour after the load. You give the load here of 75 grams, and then 1 hour should be less than 180, and 2 hours should be less than 153. Right, that's done with the 75 grams glucose. That's an easy one. Initial madam glycemic index tha. Glycemic index, you'll have to tell me glycemic index. What was the choices you'll have to give me? Unfortunately, since it was not given to me and I don't want to discuss that, I will not be wasting time asking you the choices and then build up a question live, because we must get to the surgery discussions which are immediately after my discussions. Alright, let's move on and see. Antidose given in Rh negative mother. So, remember the prophylactic anti-D which is given at 28 weeks is 300 micrograms, and after delivery, excuse me guys, after delivery, excuse me, 300 micrograms IM again. But of course, best is do the Kleha-Betke test. Do the Kleha-Betke test. See, we taught you so many things so that the basics should be very simple for you to manage. So, basis is you give a prophylactic anti-D at 28 weeks and then you give another anti-D when the patient has delivered and the baby is positive, give another 300 micrograms, right. So, that is fine. At 11 weeks, patient is in labor, supposed to undergo cesarean section. Patient is in labor, supposed to go cesarean section. Given oxytocin 3 hours back. Now SpO2 is decreased. Next best treatment, stop oxytocin definitely. See, that is showing that a patient who is having loss of oxygenation because of oxytocin, that is precisely what is been teaching you, that this is water intoxication. Too much of oxytocin, patient was in labor for a long time, too much of oxytocin, this is what happens. A lot of people don't think of water intoxication as a problem. This is a direct question for that. So, it is a good question on water intoxication, that if there is too much of oxytocin given, too much of fluid causes cardiac failure and the patient will have loss of saturation. Early signs are that there is a loss of saturation. Yes, stop the oxytocin first thing. Yes, prophylactic dose is fine, that is all good. Antidose is given, that is fine. So, yes, we are just discussing the same thing again and again. So, I think I am going to say thanks and I am going to excuse myself because I think I have overshot by 13 minutes already. So, anything you want to quickly ask me, you can ask me. I will give you one more minute. Otherwise, the questions were fairly good and I am sure you did a very good job. I am sure gynae, I am clear. I will have to see what questions came to Dr. Pritesh and Dr. Marwa, because if you have done these big 3 subjects, then at least you sleep well tonight. And these 3 big subjects have been done well, and then if PSM is done well, then you are almost passing. But like I always say, if you have not done the small subjects properly, then doing only the 4 big subjects properly, not the best. So, those who are writing this exam just for the sake of writing, just finished your exam, came to India, I am just giving a trial exam this time. If there are some people like that, I mean, if you pass, I will be the happiest. If you just in case you don't, then remember, please read the small subjects always. Big subjects will give you the bulk of marks, but they will not take you much beyond 110, 120 marks. You will pass because of the smaller subjects. Big subjects will give you a bulk, after out of 40, even if you have 25 to 27 marks, you pass in all these 3 big subjects, but you will still not pass the exam. So, if you want to pass, read all 19 subjects. Big subjects, read them good 1 or 2 months before the exam. Last few days, read for the small subjects very well. They will help you pass the exams. Right, guys, anything else you want to ask me? What is happening here? I am not able to see the chat. What happened? No, I am not able to see the chat. Stop हो गया क्या? Can you just help me? Yeah. PopQ classification, what they asked? PopQ classification, very good. I mean, like, PopQ classification is the best method of classifying. That's why I told you. I mean, I hope they did not ask you to, if they gave you the, please tell me, jaldi se batao. Did they give you the findings and told you what is the grade of prolapse by PopQ classification? Did they ask you that? Or just asked you what is the best method of classifying prolapse? Please tell me immediately. Coronary sampling at 11 weeks gestation anti-D dose. So before, if it is before, then it is to be 50. We can give 50 to 100 depending. So if it is around 12 weeks, give 100. If it is before 8 weeks, if there is some abortion or ectopic, we give 50. So around 11-12 weeks, the answer best would have been 100 micrograms of anti-D if that was the question. Okay, PopQ wala batao mujhe jaldi se. Tell me guys, what came? Best method to classify is PopQ. That's what generally comes. Even in NEET exam and INICT, I have not seen them to tell what is it, because PopQ will be a very difficult thing to manage just in MCQ. So thankfully, they are not asking that so far. So yes. Analytical reference point, yes. Anterior wall, posterior wall, cervix, vault, the highest part on the posterior fornix, vault. What was the options? Choices batao, kya choices diya tha? Tuberculosis, genital tuberculosis, fallopian tube is the first site which is affected, yes. पोस्टिव फॉनिक्स होगा, ठीक है, हाइमन भी होता है. पोस्टिव फॉनिक्स, यस, दैट्स फाइन, ठीक है, फाइन. पॉपक्यू में थोड़ा सा पूछने लग गए, ठीक है, फाइन. Fine. Reference points will be asked. That's okay. I'm sure you could get that easily depending on what was asked. Chalo guys, so we'll format these questions and we'll get back to you on a different forum. So far, I think I felt the questions were all to the expectations and not out of out of course kind of feeling. I'm sure you did not have. One or two questions looked like a little tougher than others, but they were just tougher. They were not out of expectations. All right. So I hope all of you did well, and I hope each one of you who've been preparing for the last 6-7 months and have done the basics, those people will pass easily this exam. And those who are writing for the first time and they also have a very good chance of passing this exam because it looks like it came easy. So good luck with your results, guys, and we'll keep meeting on these forums. Please keep reading PrepLadder app, and please visit us on the site for all the YouTube updates, and there are so many ways we are connected with you. So keep in touch with that. All right, best wishes with the exam and the results. Thank you.